We're going to move now into the presentation on insomnia. Very pleased that Dr. Atul Khullar is joining us from Edmonton. So he was up earliest today. He receives a virtual coffee from us from McDonald's this morning. Atul's a good friend and colleague. I've known Atul now for 2 decades. And when I was thinking about who should we have present at our Braxia Institute, as always, I want people who are the best at the topic. And I have no hesitation in saying that not only is Atul the top person in Canada in sleep, as if not more importantly, I really trust his judgment when it comes to how we should be carefully thinking about treatment selection. I was glad you're available, Atul. The floor is over to yours. Looking forward to your presentation on insomnia.
Thank you very much, Roger. Thank you for that kind introduction and the checks in the mail. And Roger was also one of my elective and fellowship supervisors. So that because mood disorders is also near and dear to my heart because I do both. But today's topic, the mood stuff, has been covered extremely well by my colleagues. It's kind of how insomnia works into all of this. And there's many other sleep disorders that we could discuss, but for sake of time, we're going to do sort of a whirlwind tour into the management of insomnia and kind of hopefully shift some paradigms about how we think about it, because we need to really look at this, especially in combination with these comorbidities and mood disorders. Again, my disclosure slide, like also to thank our private sponsors for making this happen, and the Braxia Institute for really pushing this sort of knowledge translation forward. It can't have enough of it. So it's not surprising, we've all seen this day in and day out, but what are the sleep changes that we've seen, with COVID-19? I did not make this term, chromosomnia. It is pretty catchy. It's the National Sleep Foundation's term. And there has been a small proportion of people that once you subtract their ridiculous commute, they've actually slept better, but that's the exception rather than the rule. So the trend has been, and this is not by no means everybody, but people have had later bedtime, yet reduced nighttime sleep duration and then increased daytime napping. So circadian signaling has definitely dropped off and often does with any semblance of isolation for multiple reasons. This is not an unexpected factor. Anxiety, worry, depression, isolation, your mild mental health illness becomes moderate, your moderate becomes severe. I think we've all had people who were perfectly stable who came out of the woodwork and have sort of relapsed. I think one thing that's been really underplayed in the pandemic is less access to healthcare. I see a lot of people who are keeping their sleep problem at bay, their comorbidities at bay, with going to the pool, with exercising, with going to the gym, and going to their physio, and partially because of closure and partially because of their own sort of assessment of risk, they've stopped doing these things. That's really created detriments in people's sleep because it's often the comorbid issue. The only time our emergency room at the hospital I consult at was overflowed was actually after the acute pandemic, when everyone came in for the healthcare problems that they were avoiding for a couple of months. Our homework boundaries have been blurred, and there's been obviously a daily life disruption, all things that are not, does not facilitate good circadian rhythm monitor, consistency and sleep. I think a lot of us have felt this way, in the last 16 months in some way or another. Mine's like one of those internet browsers, a bunch of tabs open, you don't know which have crashed, which haven't, and really just kind of, there's some strange music coming from a website that you're not quite sure of. I think a lot of people's brains feel like that, and as Roger pointed out, the chronic stress is not really particularly healthy. And it's a good literature on post-pandemic, and let's just hope we are post-pandemic to some degree of almost a PTSD-like state, and that is definitely not going to promote good sleep either. I think all these disorders that we've been talking about today, the best sort of heuristic I can give you to kind of, they're not separate pods. There's, their structures are right next to each other in the brain. They share neurotransmitter. They're all dysfunctions of arousal. And I really would encourage you all to think of insomnia as a dysfunction of arousal. There's a physiological arousal, there's a cognitive arousal. You get this tired but wired feeling. I could argue this for anxiety, and, working in insomnia is you're basically doing mood and anxiety, whether you care to admit it or not. And, a fair bit of, hyperfrontality or whatever you want to call executive dysfunction or ADHD. You have all these sort of features that really disrupt people's arousal and then subsequently disrupt their sleep. So they're reporting the phenotype of sleep problem, but really it's a dysfunction of arousal. And you can also see that with chronic pain, because pain and sleep, just because of the arousal system, are inconsistent neurological states. So what do we do clinically? Again, sleep-wake diaries, just to get a sense, patterns, useful targets for behavioral treatment, know what's going on. I wouldn't do this, be pedantic about it. Some people are doing sleep logs for months, for years, and unless you're actually doing therapy, I wouldn't really suggest that, because you start losing the focus on what the net is, and that's your daytime function. And you get a little too hung up in the sleep. And this is my issue with actigraphy. So true actigraphy is kind of a rest activity pattern that's related to movement. And there are things that have been validated and things that have not, such as Fitbits and mobile phone apps, which many people use. And, again, they can be reasonable in the short term. There is some data, but I think especially, in the population of mood disorders who are on a number of medications can really mislead actigraphy and make it very difficult to fully delineate exactly what's going on. The other problem is, it can really reinforce maladaptive cognitions. A lot of the, phone apps give you a score of the quality of sleep, and that's complete, basically hogwash. The quality of your sleep is how you felt about it the next day. It has nothing to do with how it was measured. And you can get into this bad sort of, pattern of, looking at basically, oh, I'm going to have a bad day, precognitively, set yourself up for failure just because your sleep score was poor. So there is a use for it. They are not bad at telling you if you slept or not for most, issues, but ultimately I wouldn't put too much stock in them versus sort of just beginning of diagnosis. It's really how the patient feels the next day. That we have sort of doing the sleep study, and again, we don't usually do it just for the insomnia assessment. We do it for sort of other issues, sleep apnea, parasomnias, other sort of things. But I think the usefulness of a polysomnography is to see the degree of misperception that can be there. And unfortunately, with most sleep clinics across the world, the EEG is not read with a lot of detail, and that's a lot of missed data. And hopefully, machine learning and going forward will kind of help us, get a better sense of, from the sleep study, the quality of sleep. We're not quite there yet. So again, right now, it's really ruling out other issues and often reinforcing to the patient that sleep is maybe a symptom. So they have a normal sleep study. A lot of people, at least in my clinic, then subsequently be like, okay, yes, Dr. Khullar, I'm depressed. I just didn't want to admit it. I wanted a sleep study first. Yes, I'm anxious. Yes, this could, and it's astonishing actually, especially for psychiatrists, how many initial antidepressant starts I do in the sleep clinic or recommend. Now, obviously, measurement-based care, as we've seen throughout. Now, for sleep, I think there's a caveat. The two most common things, at least clinically, what I would use is the insomnia severity index because of ease of use. There's a more sort of detailed scale, Pittsburgh sleep quality. It's a little more cumbersome, but it's probably, I would say, the industry standard. I think the caveat with this, and we've talked a lot about comorbidities today, all these things run together. These can't be done in isolation. And that's one of the biggest mistakes I see in sleep, is that the overfocus on the insomnia complaint to the exclusion of what you can see. You must consider other scales: depression, bipolar, ADHD, sleep apnea, restless legs, circadian rhythm. And I can definitely take some questions about which scales are useful. And so you get sort of a dimensional measurement. So if the insomnia scale is sticking out from some of these other scales, well, then by all means, treat the insomnia. But I can tell you, in sort of a random sampling of people that get referred, and they were referred for sleep, even though there's a bit of a bias because people also know me as a mood and anxiety specialist, I see tons of residual depression, people who screen positive for ADHD. And one of the biggest things, kind of one of my near and dear to my heart as well as Roger, mixed states. If you have a depression patient that is chronically not sleeping, be really, really wary of a mixed state. And those, the four A's that Roger talked about, I would add the fifth A, and that's resistant insomnia. So it doesn't start with A, but it ends with one. So again, like we said, is it the insomnia? Is it the comorbidity? Now, we should treat the insomnia separately, but, not to the exclusion of treating the comorbidity, and treatment plan sort of needs to be set up. So what comorbidities? There's a laundry list of things that can disrupt our sleep. I think we all know this. So, focusing on sort of, what's more common, in sort of your first visit, it's really the big four are quite clear, right? It's depression, anxiety, chronic pain, sleep apnea, and then sort of a shout out to drug medication, restless legs. Within that sort of depression rubric would, I think, really be very wary of mixed states or eventual bipolarity. Roger showed the 1 to 2% rule, and often that shows up as resistant recalcitrant sleep difficulties. And you can see here that 3/4 of people have a major comorbidity, and that's really determinant that's the biggest determinant of what medication you use for sleep. So, obviously I get asked a lot, should I use quetiapine for sleep? So the short answer is no. But if you have a mood and anxiety disorder, it may move up the algorithm. So I think it's really important to realize, because of the ubiquity of, cannabis for sleep marketing by the companies, which are not held to any semblance of standard, is cannabis a good idea for my sleep? And I would say the short answer is no. But if you're in severe chronic pain, it may move up the algorithm. So I think the algorithm is really dependent on that patient's sort of pattern of comorbidities. Because treatment, requires looking at multiple layers, either in, Roger talked about stress, you got poor sleep behavior, throw in a primary sleep disorder, pain, medications, meds, mood and anxiety, ADHD symptoms, body clock issues, genetic factors, all that smushes together to create a person who doesn't sleep. So the last patient I saw on Friday, genetically poor sleeper, delayed circadian rhythm, depression with probably some mixed features, some sort of phenotype therein, had a level of hypertension as well as some neuropathic pain, throw in some snoring. She had bad sleep behavior, and it was currently under some significant COVID-induced stress. So you have to almost create a treatment plan, as many of you may remember from internal medicine training. Because I think the biggest mistake is, and I use this slide in jest, often when we're treating the sleep, we're putting a finger in the fire hose. But patients tend to over-report cognitively their sleep problems. So there's kind of a bias between the patient and clinician to collude to perhaps over-focusing on the sleep part, where the real issue is sort of the fire hose of comorbidity. So, in treatment for insomnia, and again, make the diagnosis, review the comorbidities as we discussed. And, unfortunately, the literature and people, and a lot of this comes from the history of sleep. There's, in a good way and a bad way, there is a lot of influence in the history of sort of, especially at least American or North American sleep, the role of psychology, and that's very useful. The problem is, these aren't Democrats and Republicans, or these days, you really need some bipartisanship when you're treating sleep. And pharmacotherapy and cognitive behavioral therapy aren't mutually exclusive, like some authors or some, people who say it is. They need to sort of be combined, especially in resistant cases. And, we would never say do one or the other for depression. So we shouldn't really be saying do one or the other for insomnia. Yet there's this sort of, push to be like, you should only do cognitive therapy and you should never use a sleeping med. And a lot of this comes from the academic centers, and it's really it's not particularly useful to treating sleep. So these things have to be done in a synergistic fashion, as we talked about earlier. And we all know behavioral therapy. Most people have done sleep hygiene. It doesn't actually work by itself, except in the mildest cases. Really important to look at some semblance of sleep consolidation or stimulus control and not lie awake in bed for long periods. And they may be too anxious to do this and may need some semblance of relaxation therapies. Now, I think the important thing, this is well known, but often it's that people are so pre-contemplative about making any change unless you challenge their cognition. So I invite you all, if you're interested in this area, to give your next 5 to 6 clients or patients, it's called the Dysfunctional Beliefs and Attitudes About Sleep Scale. Takes about maybe about 5 minutes, and it has 16 of the most maladaptive cognitions, common maladaptive cognitions about sleep. And it's utterly amazing the weird myths people have about their sleep. And, that translates over socially, I'm sure you see as well. And unless you address that, they're not going to do the behavior. And so I think that's a really important point, is to kind of target some of that, at least, with psychoeducation, at the very least, to kind of get them on that path to kind of improving their sleep. An example is, your sleep's not going to be perfect every night, yet there's this expectation it is. So, goals and expectations are important in this business. And then obviously, and I'll focus the second part of the talk on pharmacotherapy. The OTC meds, the benzodiazepines, hypnotics, and sort of other various sedative medications that we use. So like I said, this is sort of the cognitive structure, we can all do in a brief appointment. And these are common cognitive errors, in many disorders in mental health. Again, realistic expectations, don't over attribute to insomnia, don't catastrophize, don't give too much importance, and develop some tolerance to the effects of insomnia. And this should really be done, at the beginning rather than down the road. It's not formal cognitive behavioral therapy, but it's reframing things, I think, to some degree. And some people may need a little more assistance than others. Treatment of insomnia, I think it's really important to understand that just because you knock somebody out doesn't mean you've increased their alertness. So everyone's like, put me to sleep, put me to sleep, put me to sleep. I'm like, yeah, I can do that. I don't know how you're going to function the next day. So it needs to be a balance between providing sleep, but I actually don't even care how you slept. I really care about your energy and function during the day, with sleep as a foundational part of that. So another analogy would be in depression. Yes, your mood is important, but mood's not going to get you back to work. You really need to improve your cognition, right? So you got to improve their energy and function, and deeper sleep is a foundation point to that. Now, if these don't connect, like often they don't, is there a comorbidity that may explain the sleep issue? And the clinical example I will always use is, the Gravols, the Tylenol PMs. They will provide deeper sleep, but when you challenge the patient, say, how did you think the next day? How did you actually feel? It'd be like, oh, I nearly crashed my car. I, make mistakes at work. Again, that is the classic example of these two not connecting. So really, your sleep intervention really needs to increase alertness. It's not just hours of sleep, not just an accounting. So the goal is to rise and shine at the same time. So again, I'm not going to spend too much time on this. Wake sleep cycle, it's a balance between opposing neurotransmitter systems. So sleep is determined by balance of sleep and wake promoting systems. And this is an important conceptual heuristic, because there are drugs that promote sleep, usually through the GABA system, and then there are drugs that block wake. Erection, as Roger mentioned earlier, is the newest one. The Erection antagonist is a new method of blocking wake, which is very fascinating and may let us access phenotypes of difficulties that we couldn't reach before. But traditionally, we've had things like blocking histamine, and really, certain types of norepinephrine and serotonin antagonists would block wake as well. So, and some drugs do both. Like, trazodone, for example, is probably an element of both. So does quetiapine. Our traditional sleeping pills have been straight sleep promoters, and the Erection antagonists are a straight wake blocker. So it's that sort of teeter-totter, and we don't have a good sense of how these phenotypes present, but this is kind of how the sleep cycle works. So you're either promoting sleep or blocking wake, and in very resistant patients, you end up doing both. So you don't want to push too much on one side, over promote sleep, because that's what leads to side effects. You want a balanced promotion of sleep and wake blocking as best you can, with sort of the comorbidity and the phenotype of that patient. So these are indicated medications. Indication, we all know, is a political beast. I think things should be de-indicated after a period of time if they've proven to be difficult, but that rarely happens. We have 4 benzodiazepines that are actually indicated with very old studies. I think, as Josh said, they've shown to be sort of efficacious, but not necessarily effective, in the real world because of sort of the side effects. So, and, a lot of us don't even use these benzos of various sort of half-lives. Now, the Z drugs, I want to spend a minute here just discussing. They're non-benzodiazepines in terms of their chemical structure, but they hit the same receptor, sort of the GABA A. But they're best thought of as partial benzoagonists. But to conflate the two, and they get conflated a lot. Don't lump them together. They're different drugs, right? And it's very frustrating when people lump them together. Yes, they share similarities, but they're a more specific way of creating sort of a sedative hypnotic. They're not such a blunt instrument. And the most specific one is the newest, sort of the isomer of esopiclone, or Lunesta, which is by far the most sort of tailored, specific Z drug with the most evidence. probably the least side effects. Still has some, but least than the older sort of zolpidem or zopiclone. And for those of you who still had people that respond to the ultra short acting one, Starnock or Zaloplan, you can still actually get it from a compounding pharmacy in Canada. It's not commercially distributed. So those are sort of the sedative ones. And then we have the wake blockers, low dose antidepressant, doxepin, which wasn't particularly successful because it isn't that potent a wake blocker. And as we said earlier, dual orexin receptor antagonist, Dayvigo, because this is where orexins, at least clinically, have really shown their worth, is really in modulating the sleep system. As Roger said, there's many other possible options for them. They're very key to the hypothalamic control, but nothing has fully really panned out, antagonist or agonist, except sort of control of sleep, but the studies sort of are ongoing. So like I said earlier, this is the difference between benzos and Z drugs. The benzos, hit this GABA A alpha subunit as well as many other things, but this is the best studied one. It just hits them all very hard, giving you all these problems. And you can see zopiclone is probably the most benzo-like. Zolpidem just is almost just a straight knockout pill with all the attendant memory issues. And you can see S-zopiclone or Lunesta nested right in the middle is probably, the most balanced specific Z drug to promote sleep. And like I said, not a lot of head-to-head studies, but clinically, this is sort of the reason, and most people's clinical experience is that this is definitely a more specific, sort of cleaner Z drug. Increasing desired effect by minimizing adverse events. So the operational heuristic would be sort of zopiclone would be Celexa or citalopram, and S-zopiclone would be Cipralex or escitalopram, a more specific version, giving the increased desired effect while minimizing, not eliminating, adverse events. And then this is the Erection pathway. Like I said earlier, very central hypothalamically, has sort of projections all over the body. We're just beginning to understand that. We only discovered it about 20 years ago. And basically, they're neuropeptides that they do other things too, many other things, but they promote states of wakefulness. So there's A and B, two different types of receptors, and the dual orexin receptor antagonist, competitive antagonists that dampen excessive wakefulness and normalize sleep-wake function in a different fashion than, and for a different group of patients. Not going to be a panacea, but definitely, like I said, can access a degree of patients, which we're not quite sure who yet, that we couldn't really do before. Now, the initial one never came to Canada. Those of you in other countries may be aware it's called suvorexant. But lemborexant is a better version because it's on and off the receptor quicker. It has a more sort of duration of action on the receptor that's consistent with a 7 to 8 hour sleep period, where suvorexant was a little stickier. And as Roger said, there's a number in development, at least for sleep and maybe other areas, but sleep definitely is closer to the market at phase 3. Now, when you combine this in a little bit, this year's study, these are only ones in America, they compared sort of all the hypnotics as a meta-analysis and insomnia without comorbidities. So again, the clinical trials, which may not be real world patients. But what you did see there was in terms of sleep quality change and dropout rates, sort of barometers of efficacy and tolerability, you can see that S-zopiclone in the US, there was no zopiclone in the study, and lemborexant wasn't out yet, was clearly shown to be superior to other sort of drugs of other classes, such as suvorexant, such as shorter acting Z drugs, the melatonin receptor agonist was a fascinating product we don't have in Canada, and low-dose doxepin. But you can see that's very limited. This is the off-label usage. You can see there is other benzos. I get asked a lot about, do I use sedating antidepressants? You can definitely, they do some positive things to sleep. The data isn't there, it's small. Be aware that the fall risk is very similar in the elderly, although it probably would be better for the memory. I'm not a big mirtazapine fan unless someone really wants to gain the weight, and it doesn't matter what dose it is. The company did numerous studies to try low dose because it was such a good sleeping pill. Those people still gained a ton of weight, but, and I would kind of, trazodone does just a lot of positive things to sleep, right? It's not for everybody. It's not sort of a panacea, but, and there's a ton of evidence, but, it is usually outside sort of the newly documented fall risk, reasonably safe, but again, I'm probably only using these if there's a comorbidity outside of trazodone, which I will give the nod to for just straight sleep sometimes. And again, amitriptyline, nortriptyline only if there's another comorbidity. And like I said, if there is a major mood and anxiety, quetiapine, other atypical antipsychotics with a kind of, mildly sedating effect, less sedating or mildly sedating effect, such as docenapine or lorazepam, can be used if there's a major mood sort of anxiety issue for which they have evidence. And that's what I think people don't know. I challenge you all to look at all the people that you have that slept on quetiapine, and I'm sure most of them would meet the criteria of GAD, and quetiapine has good data at 50 milligrams as an effective GAD treatment. But I think it's really important to counsel the patient that, yes, this is helping your sleep, but this is why this is helping your sleep, rather than saying it's a sleeping pill. Then gabapentin and pregabalin can do some positive things to sleep, but again, only for sort of age areas where they have evidence for, restless legs, chronic pain, perhaps even anxiety, right? And you would use much lower doses than you tend to use sort of in the pain sort of literature. And like I said, the key is the medication decreasing comorbidity or improving sleep. There's a direct effect, but I really think the money is where, if you're going off label, is to really to decrease the comorbidity. So this gets us to our natural agents. L-tryptophan, a lot of good theory, almost no evidence, but from a risk-benefit prescribing point of view, has almost no side effects. So give it a shot. It should be taken with a carbohydrate and not with protein to promote absorption. And clinically, sometimes it works. Melatonin is an excellent way to start fights at sleep meetings. If you like to start sort of rousing academic discussions. There is a lot of data on melatonin, but I think when you summarize it and a meta-analysis showing a modest effect size, I think it works better in certain subpopulations, the elderly, developmentally delayed, maybe as an augment in patients with mood disorders who have melatonergic dysfunction. There's limitations in North America, at least, with dose and purity. If anyone is on here from Europe, it's a pharmaceutical product, and then you know what you're getting. The other problem with melatonin is it has a dual role. It's also a circadian rhythm shifter, so you do have to assess the circadian rhythm prior to using it, because if you have a delayed sleep-wake phase, it will not work well as a hypnotic. It's best given earlier at a smaller dose to shift phase, whereas if you don't have delayed sleep-wake phase, by all means, you could consider it as a hypnotic. And none of the studies have done that systematically. Valerian has some evidence. I can never get it to work. Again, you will have to address cannabis. The data is extremely limited. There's a recent study showing that, yes, cannabis helps insomnia, but at the end of the day, it was just a proprietary extract of THC, which is not surprising to anybody. Yes, they studied insomnia. Yes, it showed some effect over 2 weeks, but really at the end of the day, it was just like, I could have told you, a lot of people could have told you that THC helps insomnia. That doesn't mean it's the best thing for it. A lot of things can knock you out. I can show you a study with Gravol, right? That doesn't mean, again, it's the right thing to use, right? So, and again, like I said, if there's if the insomnia is comorbid, and this is what Health Canada says, with conditions with cannabis evidence, it could be considered, or in a resistant case. So I do prescribe cannabis, but never straight for sleep with a major other issue, which usually ends up being chronic pain, where the evidence is, and maybe in resistant anxiety. But, again, that would be really stretching it. And I guess the key is not to be too parsimonious with your sleep medications, because then they're just going to go to Shoppers or Jean Coutu and get the OTCs, which there are numerous of them. Serious anticholinergic side effects. Anticholinergic might be short for anti-cognitive, and we've heard repeatedly over the years from Roger about how important cognition is. These are anti-cognitive drugs. They knock you out, but they don't help your cognition. And if you become too parsimonious and rigid about prescribing sleeping pills, your patients are just going to go get this or get uncontrolled cannabis or drink, right? So I think there is a throwing the baby out with the bathwater by some of these deprescribing mavens about this. And just be very clear what you are doing with the sleeping pill and make sure it's not a Band-Aid for another comorbidity, I think, is the key point. and that gets us to our off-label long-term usage. It's a risk-benefit ratio. There is data up to 1 year for numerous sleeping pills. The 7 to 10 day thing that the pharmacy does has no basis in data. It's complete garbage, and it was basically made in a Health Canada boardroom, right? So the US part of monographs just say not studied past 6 months to a year, right? And that's what I would say when I'm counseling patients. Again, some people will need long-term usage, risk-benefit ratio, helpful to document the failed trial or refusal of cognitive therapy, and 30 to 40% of people will fail it. And I think this is the key, like I said earlier, it must be vigilant for the emerging comorbidity, especially if that medication stops working. The clinical trials show very little tolerance with Z drugs, and it can happen, but it's usually when they're used improperly. Right? If I see Z drug tolerance past, a few months, I've usually missed something. Something has evolved, they've gotten more depressed, maybe there's sleep apnea or sort of mood polarity issues. So don't throw the baby out with the bathwater. So to sum up, referrals for insomnia, know what your sleep clinic does. It may be limited to only ruling out other sleep disorders and studies. Understand the interplay between comorbidities and insomnia, more intense CBTI, may improve with telehealth, and ensure someone clinic has someone that can deal with the insomnia. So pro-sleep strategies and not over sedating, I think, are the two keys. And thank you very much for your attention, and thank you very much for having me. It's been an honor to be here.
Atul, that was great. Just a reminder to everybody, put your questions in the Q&A rather than the chat. I've been asked a lot of questions about the program. It will be archived on the BCDF Foundation website. So it's www.bcdfoundation.ca, and we'll circulate that email to you. Atul, lots of questions as always. Really, really tight, short answers. We'll get through as many as we can. Short answers. What do you recommend pharmacologically for restless leg syndrome?
So the short answer, the first step is magnesium and iron. Do check the ferritin, make sure it's above 75. 3 classes, depending on their comorbidities. I would say gabapentin, pregabalin, dopamine agonist, or if push comes to shove, a benzo.
Okay, we thank David for that question. Question from Pierce. Can you combine Z drugs with Dayvigo?
Not officially, but I think it makes a lot of pharmacological sense. We all do rational pharmacology, and that is actually probably my best use of it, especially in resistant patients. Do add it and try to taper the Z drug. Don't just switch straight over unless the Z drug's not working.
Question from Viral, and the question is, why are they called wake blockers and not wake promoters? Short answer?
Because they're antagonists. So it's a good point. And so you're blocking wake at night to promote wake during the day. But that's an excellent point. But there's no data on the wake promotion. There's no data on the alertness. So that's why. But I guess at the end of the day, positive sleep is wake promoting. That's a good point.
Question from Robert, and that is in your view, should Z drugs continue to be scheduled? Should they be descheduled?
That's a good question. I think I think they should be descheduled, to be honest with you, right? Yes, there is evidence, but, people abuse gabapentin, people abuse quetiapine. There's been data showing that if you schedule these sort of drugs, New York State had tried this and people just drink more. There's the reluctance. So they need to be used with caution, but I could argue that Seroquel should be scheduled if a Z drug is scheduled, given its side effect.
Yeah, I have to agree with that. One final question from Gulshan, and the question is, patient has a diagnosis of hypomania, so I presume that's part of either bipolar 1 or bipolar 2. Patient's a shift worker who uses alcohol and marijuana. Is alcohol and marijuana the appropriate treatment?
No, absolutely not, because it's going to destabilize them. And I guess the question is, depending on the brittleness of his bipolarity, he may not be able to do shifts, but if he is, the combination of usually some sort of short-acting sedative to help is probably going to be a better option. And this is someone to the point that may just need long-term medication for sleep because he has a major mood disorder.
One final question in the spirit of measurement-based care. Everyone's busy, everyone's scaled to death. Is there any patient-administered scale in the waiting room that's not of theoretical importance and not of importance or interest to academics, because academics have got all the time in the world on their hands, but people who see a lot of patients, should we rely on a scale? Is it one you like for the waiting room? If not, is it based on clinical history?
That's a good point. Both my parents are family docs, so it can't be done in 6 minutes. I hear about it. So the ISI, in conjunction with major comorbidity scales, is the way to go. such as a D87, an MDQ, maybe Rogers Rapid Mood Scale, a sleep apnea scale, and a restless leg scale. Do not do the insomnia scale in isolation. You will not be very happy with it.
An ISI Insomnia Severity Index, is that right? The right
That is
acronym?
correct, yeah, and it is pre-download.
We love that price. Atul, thank you. That's fantastic.